2 days ago, the New York Times ran an article questioning whether cognitive decline can be reversed. This despite peer-reviewed studies, clinical trials, and thousands of patients around the world who claim to have done so. Today, I'm sitting down with the man at the center of the controversy, Dr. Dale Bredesen himself. We'll talk about the science the headlines ignored, the patients whose lives have been transformed, and the question that we should really be asking: what if Alzheimer's does not have to be inevitable? What if there is a lot we can do to prevent and reverse early stages of dementia before it becomes full-blown Alzheimer's? Knowing that Alzheimer's is just one kind of dementia, but the most common form. Our conversation is not about controversy. It's about hope grounded in science and data, and a future we can still choose if we act in time. Dr. Dale Bredesen is a renowned neurologist and an expert in neurodegenerative diseases like Alzheimer's. He was the founding CEO of the Buck Institute for Aging in California and currently serves as the head of precision brain health at the Pacific Neuroscience Institute. He is also the chief science officer at Apollo Health. Dr. Bredesen is internationally recognized for his groundbreaking research, which has led to the development of the RECODE protocol, which stands for Reversal of Cognitive Decline, a comprehensive approach aimed at preventing and reversing cognitive decline. With a medical degree from Duke University and faculty roles at universities like UCSF and UCLA, Dr. Bredesen has authored several influential books, the latest one being The Ageless Brain. We will talk about that book as well. His book has opened new doors in the fight against Alzheimer's and dementia, offering hope to patients and families worldwide. Welcome to our conversation. Thank you for joining, Dr. Bredesen. I am so excited for our conversation today.
Great to talk to you, Dr. Sembi. Thank you very much.
Of course. And what I did was I went ahead and recorded an introduction to you, using your bio from your website, and also a little bit about the article in the New York Times from a couple of days ago. But before we get into that, would you just share a little bit about yourself in your own words, and then we'll get into it?
Yeah, so I came through a very classical training. I graduated from Caltech, worked in chemistry, worked at MIT, and then went to Duke Medical School to learn about the brain and medicine, and then went to UCSF, which has a wonderful neurology program, and became a neurologist, and then worked for Dr. Stanley Prusiner, who won the Nobel Prize for his work on discovering and characterizing prions. And then way back in 1989, set up my own lab. The whole idea was that the area that is understood and treated the poorest in medicine is neurodegeneration. Whether you have ALS, Alzheimer's, Lewy body disease, frontotemporal dementia, progressive supranuclear palsy, just go right down the list. These are all terminal illnesses without any effective treatment. So I wanted to understand, could we develop a better understanding of these diseases so that we could ultimately begin to be pointed in the right direction toward treating them? And so, I ran a lab for 30 years, and, we used the usual NIH grants and philanthropy and, whatever we could get to look at the molecular biology of neurodegeneration. But what happened during this time is we finally got to the point where we thought, okay, we understand a little better about what is actually happening with these. So let's see if we can use that knowledge to translate it into the beginnings of, hey, can we make a difference for human beings? And so we actually tried to start the first trial that would use multiple different approaches where you want to address the different things that control the process, because we came to the conclusion that was something completely different, that this is not about a misfolded protein or a reactive oxygen species or type 3 diabetes or whatever, all these, there are dozens of different ideas about, for example, what Alzheimer's is as the most common neurodegenerative disease. And we thought, it really looks like this is a network insufficiency. So what's fascinating is during evolution, the species select for the highest performance over the longest durability. And of course, that's because you're fighting with these other evolved species. So the species that's the mutants that selected for durability were killed by the ones that selected for performance. So we have these amazing performance brains. Human brain can store more information than over 2,000 home computers. So you really have an amazing supercomputer inside your skull. But in so doing, you have a scenario in which over time these things can fail and they have Achilles heels. So you look at these different networks. If the network that's associated with neuroplasticity begins to fail, you get Alzheimer's. If the network that is focused on fine motor modulation, as that begins to fail, you get Parkinson's. And as you have another one that's focused on amplification of power, when that fails, you get ALS. So you can see how these different subnetworks play a role in our remarkable brain performance. And each of these networks has different characteristics. So in Alzheimer's, we could see that there are critical pieces that have to do with ongoing inflammation, have to do with energetics, blood flow, mitochondrial function, oxygenation, all that, and have to do with toxicity. Those are the big three. And so you have to identify those for each person, as you know, and you have to address them. And so way back in 2011, we were trying to do a clinical trial. We got turned down for the trial because the IRBs wanted us to just do one thing. And we said, well, that's not the way the disease works. And so after that, I got called by a woman in San Francisco who said that her friend was a CIA agent who was failing in her cognition. Her mother had died of Alzheimer's. And she became the first of thousands and thousands. So she was patient zero who came to see me at the Buck Institute in April of 2012. And I just explained to her, this is our concept and this is the trial we were trying to do, but we got turned down for the trial. She did great. She's now come out. Her name is Judy Benjamin. She's now walking across the United States at the age of ready to turn 81. And she's already gotten from California to through Arizona and into New Mexico. And she's headed for Florida. And she's walking to raise awareness that cognitive decline can be prevented and in many cases reversed. Not all cases, and we're still researching that. Why is it that some people respond so well and some people do not? We've seen some patterns, like when people, the later you, no surprise, just like in cancer, the later you come in, the harder it is to get an optimal outcome. Of course, less compliance, less of an outcome. These are the sorts of things. People who have severe toxicity, you really have to dig in and work on that, as you've seen. So, that's kind of the backstory of how things got to where they are. And we now are seeing, thousands of people. And we've published numerous papers on this. We published a clinical trial. Of course, your colleague, Dr. Sanderson, published her own clinical trial, same idea, saw the same thing. By the way, we're in the middle of a randomized controlled trial, which compares standard of care for Alzheimer's treatment to the protocol we developed. We already have statistically significant improvements with the people on our protocol compared to the ones who are on the standard of care. The standard of care people, no surprise, continuing to go down. On the protocol, the people are going up. So there's a striking difference. And we need to get people to understand, okay, this is not the old antiquated approach of, one drug that's going to do everything. despite the fact that there are all these different contributors. And interestingly, many people have 5 or 10 different contributors. So you've got to find them and you've got to address them for optimal outcomes.
Yes, and you've covered so much in there. So now I'm going to kind of like
Sorry
parse
about
some of
that.
those things out and we
Yeah.
go back to all of those things. Okay. First thing, just going back to your choice of neurology when you were in medical school. Talk a little bit about that. Why did you pick neurology over anything else?
Yeah, I had gotten interested in the brain when I was 18. When I was a freshman at Caltech, I read a wonderful book that was called Machinery of the Brain by Dean Wooldridge. And it was talking about similarities and differences between computer calculations and computations and what the brain does. And talking about some insect behavior and hardwired versus plasticity, things like that. And I just got absolutely fascinated by this. And I thought, this is what I want to spend my life looking at because, and then of course I got to medical school after I took all the brain courses in college. In fact, they had a situation where you could then teach a seminar. So I did that at the end when I was a senior. And then I wanted to learn about brain diseases. And of course, it was disappointing to me to see that there's so little that could be done. But I thought, okay, so this is a laboratory challenge. I need to go back to the lab, and I'd worked in chemistry labs when I was coming up as an undergrad, and I thought, okay, I need to go back to the lab and look at what is driving this. Why is it that these have been so untreatable? And the surprise that came out over the years is that the way that people had conceived of these and considered these diseases just didn't fit. One of our arguments is whatever your theory is, it has to be internally consistent. It has to be that different data fit. If you make a prediction for an outcome, it has to fit. If you make a prediction for a poor outcome, that has to fit. And these theories were like one-offs. Well, maybe it's this, maybe it's that. And they just didn't have any internal consistency. So we looked at kind of the big picture after we studied all these molecules that are interacting. Why is APP cleaved the way it does? Why does it interact with 20 different molecules? What's that all about? Why does it get cleaved in 2 different ways? There are all these molecular details. But if you step back, what you see is that ultimately this is a network insufficiency. You have an amazing 500 trillion synapses in your brain. And these things have a supply and they have a demand. And when you're young, the supply is good, the demand is not so bad, and you do just fine. So literally what we found is your brain is then in a connection mode. As long as you have enough supply and not too much demand, you're in this connection mode. You're able to you've got beautiful neuroplasticity. Look how much you can remember. It's incredible. People remember books and they remember films and they remember thousands of acquaintances. It's incredible what the human brain can do. But when you start to lower that supply, and now you have less vitamin D, nutrients, hormones, neurotrophic factors, all these things start to go down, less blood flow, less oxygenation. And now you're weighing it down. You've got to now fight with inflammation. You've got to fight with organisms. As you know, oral microbiome, many of these things appear in the brain microbiome. I mean, I was taught that the brain is a sterile organ, and that turned out to be wrong. There is a brain microbiome, as it turns out. So as these things weigh this down, now the demand goes up, up, up. The supply is down, down. Now what happens? You have to respond. Ultimately, you can't support 500 trillion synapses. So one of the fascinating things is when you are exposed to these, as you know, you've got an inflammatory response as part of the innate immune system. Then you've got the adaptive immune system, which is looking more specifically. But what we now believe is that prior to the innate response, you have barrier function. So, as you know, you've got barrier in your skin, for example. You've got a barrier with your cerumen, for example. That's an antimicrobial barrier that doesn't cause a lot of inflammation. So we now realize that the amyloid that has been vilified in Alzheimer's is essentially an internal barrier. It is like cerumen for inside the brain. It will coat, sequester, isolate, and kill the pathogens without compromising neuronal function. So it's as long as you've got relatively small amounts of these pathogens, this is a way to keep your brain functioning. And indeed, it's been known for years. You can have amyloid in your brain for 20 years and never have symptoms of Alzheimer's. But once you activate that next stage, which is the inflammatory piece, the innate immune system, now you've got microglia activated, you've got cytokines coming through, you can have mast cells activated, and now you do compromise neural functions. In fact, complement covers the synapses. That was shown beautifully by Dr. Ben Barres at Stanford. So now you're in a different scenario. You've gone from we can handle these insults without hurting our function to things are worse. We've now are going to compromise our function just to survive. So as long as you can stay in that first area where you're not compromising the function, you're not activating the microglia, that's the key. That is literally the key decision point between protection without damage and protection with compromise of function. So what we discovered is that your brain goes from connection to protection. And so that amyloid is trying to allow you to keep in the protection or the connection mode. But if you override that, if you've got too much of a problem, now it will flip into a destruction, a protection mode. And so what happens then, it's not that your brain is trying to give you Alzheimer's, it's trying to survive. So just imagine that your country is invaded. You say, okay, I'm going to have to pull back. There are invaders at the borders. I can still function, but I'm not going to be able to have the whole country here. So what I'll do is I'll fight the battles here on the borders. I'll live with a smaller country for now, so that I can, and I'm going to put my resources into protection. And that's exactly what your brain does. You switch from the connection mode to the protection mode. Ultimately, you activate the cytokines, the microglia, the mast cell, all these things. And you're now living with a smaller brain. So we want to then, when we treat people, of course, first of all, we want to get in early. We'd love to get in before the activation of all this inflammation. And we'd love then, if you're already going down compromise, then we want to get in as early as possible, and we want to bring you back into the area of barrier function without compromising. We're literally going from protection to back to connection. And we see it, as you know, we see it all the time. And when you develop Alzheimer's, you go through 4 phases. You have an asymptomatic phase. Those people, we've never seen people develop dementia if they do the right things. Then you go through an SCI phase, subjective cognitive impairment. By definition, what that means is there's a problem, but you're still able to score normally on cognitive testing. Those people, as you know, virtually 100% of these people do very well. Then the third phase is called mild cognitive impairment, MCI. It's too bad that they named it mild cognitive impairment because, as one patient said, there's nothing mild about it. By definition, this means that not only do you now have complaints, but you are now not scoring normally on cognitive tests. But you are still able to do your activities of daily living. That's MCI. That's what we used in our trial. 84% of those people improved in our trial, but not everybody. So we'd like to get it in those first 2 phases. But even in the third phase, we do see improvement in many people. Over time, those people will develop dementia. That's the 4th and final phase. And by definition, now you're losing your activities of daily living. Those people we stabilize them, we see some improve, and we have had people even with MoCA scores of 0 regain their ability to speak and to be continent and to interact with others. The common thing families say is they're more engaged, to recognize people. So there are improvements, but they don't come back to perfect. Whereas, like the SCI people, they'll come back to being perfectly normal. The MCI, we've seen people go from 18 to a perfect 30. That's not the common one, but we've seen it. So it does become progressively more difficult to get a really good outcome. But in all cases, we can see some improvements. And most importantly, we've seen now people who have retained and sustained their improvement for over a decade. So I think that's an important point. This is not just a transient improvement because you're getting at the heart of the pathophysiology.
Okay, so one of the things that to me, it has been like this is a genius of those way you devise the system is like you came up with these types and subtypes of Alzheimer's, right? The inflammatory, the heart, the toxic, and all of that. And then you have this methodology where you describe it as like 36 holes in the roof. It's not just one thing. You have to do all of this. And this ties in with the network insufficiencies. Like there's many things going on and all of them have to be addressed. And the important thing is to know what to look for, what are the various things to test for, and then address those. Can you talk a little bit about how the idea originally came to you that this is not just one thing, this is many things, and our approach has to be different?
Yeah, it's a great point. So after that patient 0 in 2012, I started mentioning and showing, she came back and did videos and she talked about what had improved. And she said her memory's been better than it had been in 30 years. So she, as I say, she's done great. Actually, I'm doing a podcast with her later today as she's walking across the country. So we started then looking at other patients. And when we started looking at, okay, what's driving this problem, what we could immediately see, initially we saw 3 different types, and now we know that there are at least 6. But we saw that some people, it was really metabolic and inflammatory. They had high HSCRP. They had insulin resistance. They often had leaky gut. And you could see that, you've seen these people. They often have that classical look of metabolic syndrome with some extra weight and often, pre-diabetes and all those sorts of things. And I thought, okay, so these guys are being driven by this inflammation and some inflammation and metabolic syndrome. But then we saw a second group, and these people, the inflammatory ones, they look often the same. They're often in their 60s. They're often, they've often got the metabolic syndrome with some extra girth, some hypertension. They're often on multiple medications for that and stuff like that. And correcting that, they do very well. But then we saw a second group, and these people were often a little older, often in their mid 70s. These people, interestingly, it's what the Ayurvedics many, many years ago would call dry. They had very low multiple hormones. They would be low in estradiol, low in progesterone, low in cortisol, low in DHEA, low in vitamin D. Everything was the support. So we could kind of see one of them was with the inflammation was the demand had gone up. But in the other case, it was that the supply had gone down. You're just not supporting that network. And so we could see, we called that an atrophic subtype as opposed to an inflammatory subtype. And you treat them differently. You say, okay, we really want to optimize all the nutrients and hormones of these people who are low in those. And they responded nicely to that. And interestingly, they often felt better. They didn't have the inflammatory phenotype. They would often come in and tell me, look, I feel pretty good. I just, I play tennis, I drive my car, I'm fine. I just can't remember anything. And the spouse would often say, this person they're asking me multiple things. So they looked different. And then we found there was a third group where it was neither of those, and they were just going downhill, and we didn't know what it was. And so I started then looking into it and saying, what are we missing here? I published the very first group in 2014, and 1 out of the 10 just didn't respond and just was like going straight down. We thought, okay, she's not atrophic, she's not inflammatory, something else. And so we started looking through, what could this be? And I started talking to the spouses, and some of them had histories of really a lifelong exposure to toxins. And in fact, the very first one had a history of working in sewers. So I thought, okay, there's a toxin-related issue, even though there's nothing in neurology at that time was saying that that's a way to develop Alzheimer's disease. And then of course, I started seeing Dr. Shoemaker's wonderful work on SIRS. And so I thought, is this related? So we started checking these various parameters, and lo and behold, these people were just off the charts. They had high TGF beta 1s, and they had high C4As, they had high urinary mycotoxins. And we came over time, again, looking at thousands of people, we came to the conclusion that the 3 different groups of toxins can all give you a problem, in part because you're using up the detox system. So there's the inorganics. These are the people with air pollution, the people with exposure to mercury, things like that. Then there are the organics, and that's things like glyphosate and toluene, and unfortunately, recently, microplastics. I was again surprised, but now, although it hasn't been shown to be causal yet, there's a clear association between the amount of microplastic in the brain and the likelihood of developing dementia. So it's a concern, for all of us. And unfortunately, the brain is a source where there is a concentration of microplastics, more than the liver, more than the kidney. So it is a concern going forward. And one of the things that's been shown to reduce the microplastic burden is plasma exchange. The problem with plasma exchange, of course, is it's very expensive, but something that we may want to all consider, every 5 or 10 years, just to get these toxic burdens down, because they do invest multiple organs. And by the way, one of the things we saw on this toxic type of Alzheimer's, and we started seeing it has a different presentation in many cases. So the typical story with these toxic presentations is it's usually a woman. It's usually, now of course, 2/3 of all Alzheimer patients are women, but this tends to be even more women. These people are often ApoE4 negative, and they often will have high biotoxins, and that's the third group after the inorganics, the organics, the biotoxins. They'll often have some depression at the beginning of this, and they'll be treated for the depression without realizing this is part of their dementia presentation. They'll often present with a non-amnestic problem. So 2/3 of Alzheimer's patients present with a memory problem, but the other 1/3 present with executive dysfunction, calculation problems, visual analysis problems, so-called PCA, posterior cortical atrophy, PPA, primary progressive aphasia, CBS, corticobasal syndrome, things that are the non-amnestic. Now, of course, ultimately their memory is affected, but when the people come and they're what I think of as a non-amnestic presentation, they had trouble learning a new iPhone. They lost their job because they can't plan things anymore. They can't figure out a tip. They can't figure the checkbook. All those sorts of things. They don't recognize faces. Those sorts of things are the non-amnestic, and they are often associated with dementia, associated with toxic presentation, toxic burden. And so these people, until you recognize that and get those toxins down, it's hard to make them better. Now, to be fair, Dr. Christine Burke, who's done a wonderful job, has pointed out, and other people have seen this, but I call it Burke's Law because she was the first one who mentioned this to me a few years ago. As she pointed out, and again, others have seen this, if you do the basics and you improve them, that buys you about 9 to 12 months. They can do well. Now, during that time, you got to figure out, is there a toxic burden I'm missing? But the great news is you can get improvements at the beginning, and that will then you can focus. So I kind of think of this in 2 steps. get their basics, their diet, exercise, sleep, stress, brain training, detox, and some, standard detox and some targeted supplements. Improve their insulin sensitivity, improve their blood flow, improve these basics. And then you can, over time, figure out, do they have a high toxic burden, and start, just getting their glutathione up, just seeing. For the ones who are severely toxic, you really do want to think of one of two things: either PCIV, as you know, which you guys have used very successfully, the so-called PK protocol or the Dr. Hyman protocol, or plasma exchange, or both. I'm actually kind of interested in whether you want to do the plasma exchange and in between those do the PCIVs, because that could be quite powerful. We'll see. But those are for the ones who are truly, very, you don't have time to wait, people who are really affected. But the good news is dealing with toxins will be helpful. Now, since then, we've also identified, as you said, vascular. So some of these people, it's more of a vascular problem. Some, it's more of a traumatic problem. And then there's the what we call glycotoxic, which is really a combination of inflammatory and atrophic, because these people have insulin resistance and glycotoxicity. So you've got to deal with both parts of glucose. As Dr. Rick Johnson, professor at the University of Colorado, has shown, the fructose is a really a bad actor. It actually is worse in terms of uric acid, as Dr. David Perlmutter has pointed out, and things like the advanced glycation end products. So you want to stay away from high fructose corn syrup. It's not doing you any favors, unfortunately. So now we really understand this disease so much better than when we started 30 years ago. We can see where it comes from evolutionarily. We can see in each person why they developed it. There are new blood-based biomarkers so that you can see where you stand. You can see them improve as you get better, which we are seeing in our randomized controlled trial. And you have a huge armamentarium to treat it. The big problems now, as you know, are, number one, you can't do everything for every person. So this is where the really good doctors will figure out, okay, here's the high priority, intermediate priority, low priority. For some people, it's really about that insulin resistance mostly. For some, it's mostly about inflammation. For some, it's mostly about toxicity. So you really got to focus on those to get best outcomes. We do see a huge difference between people who do this well, the physicians who are really good at it, who've trained, and the people who really don't know what they're doing. And so that's the first issue, is you got to figure out what's the high priority. The second issue is just cost. Unfortunately, as more and more things have become available, you have these very high cost items. There's a new drug that's available through compassionate use, TB006. Now, it has helped some people, no doubt. But it's extremely expensive and not covered. So you have to decide, when are you going to use that? There are times when it's a great idea, and times when it may be a bit of a waste. So I think for all these, we're all learning about what is going to be most helpful. But here's the most important piece: virtually nobody needs to get dementia anymore. It's becoming an optional problem. If people start early, we recommend anyone who's 35 or older, please get evaluated, get on active prevention. You can find your current status with something called brain scan, where you're going to look at your p-tau217, GFAP, and your NFL. And you can just go to get a brain scan. I had it done at my kitchen table a few weeks ago. I checked my own. I'm happy to see things are good. And if you're under 60, just do it every 5 years. Just make sure that things are good. If things start slipping, no problem. You're in early, and you're going to check to make sure that things are getting back to normal. And then you can find out what's causing it. So just don't wait. If you've got symptoms, please don't wait. It's so much easier.
Right. And in fact, the video that I released only a couple days ago was all about these screening tests, the brain scan and all the three tests. And so I'm trying to kind of raise awareness and tell people, don't even wait for symptoms. I'm saying, if you're concerned, that's the time to do the test. And that might be when you're completely asymptomatic or you're in the SCI stage. So just do that. Okay, let's talk about the New York Times article.
Yes.
2 days ago, there was this article, and the title was An Expensive Alzheimer's Lifestyle Plan Offers False Hope, Experts Say. I was like, oh my gosh. I thought it was a poorly done piece of journalism.
Yeah, yeah. So the whole story here, I mean, it was a bizarre story, unfortunately. So about 8 months ago, a journalist from the New York Times contacted me and said, I would like to do a story about the controversy. She said, some people, mainstream medicine argues that there is no such thing as reversal of cognitive decline. But you guys have published this repeatedly, and we've published numerous papers. We had 100 documented cases that we published a few years ago with multiple other physicians. We have the trial, of course, Dr. Sanderson's trial. So there's abundant evidence that cognitive decline can be reversed. Not in every case, as I said, but in many cases. Again, in our trial, it was 84%. But in our trial, to be fair, we didn't take people who were in end-stage dementia. So we took people just like the drug companies who were at MCI or early dementia. So you have to look at what are the specifics here. So I said to her, look, if you're just interested in criticizing new medicine, there's so much out there about functional medicine. If you look up functional medicine on Wikipedia, it says it's quackery. We all know it works. It worked for our own daughter who had early lupus years ago, and she's done beautifully because of a functional medicine practitioner, Dr. Wendy Ellis. Thank you, Dr. Ellis. And so we all know that there is a new medicine, 21st century medicine is working. It's working for lupus. It's working for congestive heart failure. It's working, look at Chris beat cancer. It's working in some cases of cancer. It is a new medicine which recognizes root cause medicine. And interestingly for us, when you go from the test tube, that all the experiments we did over the years, and you translate that, what you end up with looks very much like functional medicine. You're saying this is a network, you got to look at all the characteristics and you've got to address those. So thanks to Jeffrey Bland for inventing functional medicine, 30 years ago now. And of course to Dr. Dean Ornish for all the wonderful work he did with heart disease. It fits the science. Interestingly, the science doesn't fit conventional medicine very well. It doesn't say, well, sure, just take a statin and everything's going to be fine. That's not the way biology works. So I said to her, look, if you just want to do a hit job on functional medicine, don't bother to talk to me. But I said, look, if you're willing to talk to numerous patients who've gotten better, to talk to numerous physicians who have seen this again and again, and to talk to other healthcare workers to say, look, this is real. There's no question about it. If you're willing to read our published papers so that you can see it's not a question. It's happened again and again and again. Not in everybody, but again and again and again. Then I'm willing to work with you on this. She said, absolutely. I'm 100%, I'm going to read these things. I'm going to talk with you. I'm going to talk. And to her credit, she talked to about a dozen different patients, physicians, and others, including Dr. Sanderson, who started Marama and has, again, seen people improve. And she talked to patient zero, who's gotten so much better. She talked to Julie G, who's gotten so much better. On and on. She then ignored and left out everything that we've done. The two patients that she mentioned, she specifically and purposefully left out their objective improvements, which we have and we supplied to her to do a hit piece on, they think they're a little better, but the implication is they're wrong. They really don't know that they're not better. Well, we have improvements in MRI, improvements in electrophysiology, improvements in biomarkers, improvements in blood flow, improvements in objective cognitive scoring. I mean, there's just no question. To deny what is right there in front of you is unfortunate. So she wrote, unfortunately, something where she deliberately misled people by just saying this doesn't work. I now have to unfortunately hire an attorney to now go after. I mean, it's sad. I don't need to be spending time taking away time from the research that we've been doing and the trial that we're working on to be talking to an attorney. But what she said is libelous. She's claiming, after all the evidence that she herself has seen, that there's no evidence that this helps. So, of course, that tells people stay away. There are going to be a lot of people who could have been helped who are now not going to be helped because they'll read this and say, oh, I want to stay away from this. And they'll go right down to a nursing home and die.
So, two questions on that. Yeah. So, are you saying that the patient whose story this is mainly, this person called Carrie Briggs, we have some evidence of improvement in her case?
So, first of all, I never met that patient. I was never made aware. She found that patient. She found a single example of someone who did. Well, of course, there are lots of examples of people who didn't improve. But the important thing, this person started with a single digit MoCA. So, this person came in for treatment in end stage dementia, okay, and gave up early after 8 months and actually had what they would reported to me then when I looked into this was they had transient improvement, but then did not improve after that. So, okay, I am sorry. The reason we're doing the research is to understand how we can get people, even in the end stage dementia, to improve. As I said, we see improvements in things like incontinence and in speaking and things like that, but not every single person. How much toxicity is going on here, how much it really takes a lot. I think in the long run, it will probably be most hopeful for best outcomes, which is always the goal, to have a couple of centers where if you're beyond, let's say if you have a MoCA that's lower than 14, you go to these couple of centers and you literally spend some time as an inpatient and you just go through everything so that you can really find out because it's life or death. You're either going to improve or you're going to die, unfortunately. So, of course, every failure bothers me. I want to see everyone get better. And as I say, it's easy when you come in early. But the current standard of care is people wait and wait and wait. So she focused the entire story, as you indicated, around one person who came in very late, gave up early, and did not do well. I'm sorry. But it has nothing to do with all the data we've published, with all the data we provided to her, and she purposefully suppressed and ignored to create a story. This does not help.
So I did an analysis of the comments, right? And now I think there's like about 500 comments. And so there's a difference between the comments that came in right away and the comments that came in day 2, and now today is day 3. So we'll see
Yeah.
what that sounds like. There are plenty of people who kind of said this approach works. They've read your books, they've either followed your protocol, they've actually been through the program. So there's, by objective measures, at least a third of the comments are positive and great comments, and about a third are kind of like, okay, well, what has medicine really given us so that like we should be open to trying this. And then there's a third which are like, they're going to disagree and kind of like so yes, this was very unfortunate that you have such a big megaphone. You can try and present information in an unbiased manner and let people decide instead of showing something that doesn't work to feed into people's negative thoughts about things and just spin things out of control. So I thought this article was very unfortunate. So you will do what is needed, and hopefully in the future there will be better information. And we will talk about your book, which I thought is really well done, The Ageless Brain. But before we go into that, there is an article also in the New York Times a couple of days ago about the blood test for Alzheimer's.
Yes.
Right. And so we have talked about the brain scan, which is a 3 test, but this one is a ratio between p-tau 217 and the beta amyloid ratio. So can you talk a little bit about this test versus the brain scan, where we do things separately?
Yeah, that's a great point. So this is a one that was just approved that looks at this. So here's the interesting thing. One of the most important things that came out of our research is we have to quit looking at this disease from a pathological lens. Oh, look, there are A beta plaques. Oh, look, there are neurofibrillary tangles. They must be bad. Let's get rid of them. That has not worked. Instead, if we look at this physiologically, what the brain is not trying to give you a disease. The brain is trying to deal with insults and a change in supply versus demand. So it's trying to help. So again, as I mentioned earlier, when it gets exposed to these various pathogens, like P. gingivalis is a classic one coming from periodontitis, it coats them, and so it says, okay, we're now going to coat them in this amyloid, and we're going to sequester them. And so what happens is, as you exceed that ability, and now you're going toward the more inflammatory piece, what's happening is you are using more of your A beta 42. So A beta can be 40 amino acids long, 42, 43. The two major species are 40 and 42. And that ratio has been shown to correlate with Alzheimer's. As your 42 is collecting in your brain, it's not going into your blood. So the 42 goes down in the blood, it goes down in the CSF, whereas your phospho-tau goes up. Now, tau is absolutely fascinating. It is a perfect reflection of this connection protection. So normally, tau is like a bolt. As you put out these neurites, it stabilizes your microtubules. So it binds to the microtubules and it stabilizes them. When you switch into protection mode, you now are pulling back. Your tau gets phosphorylated. That changes its shape. That changes its charge. It pops off the microtubules, allowing them to collapse, and it becomes an antimicrobial protein. So now you've got both the A beta, which is an antimicrobial, and you've got the tau, which is an antimicrobial. So again, it fits our model perfectly. You're trying to deal with these things. So what you then pick up in the blood is this increase in phospho-tau. And there are lots of places where tau gets phosphorylated, things like 181 and 217. But the one that associates best with Alzheimer's is at the 217, amino acid 217. And that, it looks like the enzyme that does that mostly is called GSK3 beta, glycogen synthase kinase 3 beta. Again, it's part of that connection protection. You can see, it's beautiful. You can see all the changes that your entire body undergoes when it flips from connection to protection. You see a change in thrombosis, just as you see with COVID, which all these microclots. You see a change in APP signaling, a change in p-tau, a change in A beta species, a change in what's called hippo signaling. It's amazing. You are literally changing from a peacetime to wartime, essentially. And so what you pick up in the blood is the reduction in the 42 and the increase in the p-tau. Now, in the past, it's been said you really want to look at them separately, because the first thing that happens that's more associated with inflammation is the 42 goes down. The second thing that happens that's more associated with neuronal damage is the p-tau goes up. So they just put these together and said, well, let's just do a ratio. And it works pretty well. The other thing that's been pointed out is these tests are very good, sensitive, and specific when they are negative, which is why it's great to get a negative result. It says you're in good shape. If you have a positive result, then it's not as predictive. And of course, we know when people get positive results, don't worry about it. Get on the protocol. We see people improving their outcomes. They do very, very well. The bottom line here is these are important tests for everyone, whether you get it as brain scan or you get it as the A beta 42 to p-tau, either one. These are important for understanding what's going on in your brain. And then you can go forward and say, okay, what's causing this? And then there's a whole set of things we call these RECODE labs. You're looking at, you know all these things, looking at your homocysteine, so your methylation status, your HSCRP, your inflammatory status, your various nutrients and hormones, your atrophic status, your various toxins, your toxic status, all these things. The great news is we can now get a very good look not only inside your brain, but at systemically what's causing it. And we can attack it and we can repeatedly, not every time, but many times, get very good outcomes. So it is truly amazing. We're in that twilight zone period where this is happening all the time. As Stephen Gundry said to me just a few days ago, he said, I keep working at my age, he said, because I see on a daily basis what 25 years ago I would have called a miracle. And we're all seeing it. We're all seeing people get better from their heart disease, get better from their lupus and their rheumatoid arthritis, get better from their cognitive decline, which we didn't understand these things 25 years ago. And so we are seeing, and Heather was one of the ones who said, I've seen miracles happen. So it's great to see. And of course, it's a killer when you see someone who doesn't get better and
Right.
is flailing, and it always hurts.
Right.
But that's the reason for getting those tests.
So the article says that the study found this blood test is nearly 92% as accurate as a PET scan or a spinal tap in flagging people with Alzheimer's pathology. Okay, so it's almost as good as a PET scan or a spinal tap. It was over 97% as accurate as those measures in identifying people who did not have Alzheimer's pathology.
Right.
So
So in other words, it's better for the ones who are negative than for
who are
positive.
negative. But the numbers are so close, 92, 97. It's like, right? Um, and then it also said the blood test didn't always yield a positive or negative result. It was indeterminate in less than 20% of the cases. What does that mean?
Right. So what's happened is, you're going from normal to abnormal, and there are times when you're in between and they can't tell. Are you going
Oh,
to be
it's like
normal?
the equivocal. Okay.
Exactly. So it would be just like saying to somebody, your HSCRP was zero point 0.9. Is that too high? Is that too low? Well, it's kind of on the border. Repeat it in a year. Are you at zero point 0.5 or are you at 1.5? And it's the same thing with these. So what they do is they look at thousands, and then they create a bell-shaped curve. And of course, it's not going to be zero overlap. There's a little bit of overlap between normal and abnormal. So those are indeterminate. And typically, what you want to do is just wait a year and repeat it again. And of course, during that year, do all the right things. Make sure you're doing all the things. Then hopefully you'll see that they've moved in. By the way, we've had some fantastic results where people are ApoE44, so the highest risk for Alzheimer's, already developing symptoms. They go on the protocol for a couple of years because this test wasn't available several years ago. And now we check their p-tau 217, and it's either normal or right on the borderline of normal. So they're doing great. They reflect the fact that they've been doing a lot of things right.
Okay, that sounds great. So, are you able to talk a little bit about the Evanthia trial
Yeah.
and any preliminary findings that you have?
Yeah, absolutely. And I don't know if I can share or not. Can
I
I
have
share
that. You
this?
shared it with me, so I'll be able to share it.
Oh,
Yeah.
perfect. So if you put up what I sent you, which is the interim results, so we will be completed in October, and I'm absolutely honored to be working with six absolutely fantastic physicians: Dr. Anne Hathaway, Dr. Kat Toops, Dr. Christine Burke, Dr. Craig Tanio, Dr. Nate Bergman, and Dr. David Haas. So thrilled to be working. Now, this is interim, so we're not finished yet, but we are mostly completed. Over 70% have been completed. And as I say, this will be completed in October. So what you're seeing here is the following. And again, I sent this to the reporter, and she refused to put it in this objective data to prove, of course, you can get better. So if you look at the line that's going down, 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 that's group B. Those are the people that were treated with standard of care for Alzheimer's treatment. As we know, they decline. If you look at the line that's going up, 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 those are the people who were treated with our protocol. It's a personalized precision medicine protocol. They had the things that were actually causing the problem addressed, and they have done better by and large. What you're looking at here is a composite memory score. So this is both verbal memory and visual memory. We use CNS vital signs. Alan Boyd and his group have done a great job with CNS vital signs. It's been validated on hundreds and hundreds of drug trials. And you can see this improving. And the time scale here is 9 months. So you're seeing here it goes up at 3 months, up at 6 months, up at 9 months, compared to down at 3 months, down at 6 months, down at 9 months. And we've just published, by the way, freely available online, over 10 years of sustained improvement in some people. So we're very enthusiastic about that. So these are the interim results of the trial, and we're just, as I say, finishing up in the next few months.
One more thing, which is like the original trial that was done, we said 84% of the people improved, but we only selected people that had MCI, mild cognitive impairment,
Or early dementia.
or early dementia.
Yeah. So these
In
were 19 to 30 on their MoCA scores.
Okay.
And our current trial is 18 to 30 on the MoCA scores. And when you have, when you are screened with MoCA, 28 to 30 is typically normal. 27 is borderline, but that's usually saying something is beginning to be a problem. And that's MCI down to 22. When you're down at 18, 19, those are typically the early dementia patients. So that's the typical distribution, and we're taking, as I say, 18 to 30. So it's early dementia and MCI
Right.
that are being treated. And by the way, this matches up perfectly with what's been treated in the drug trials.
What do you mean in the drug trials? Like,
So Leqembi and
right.
Kisunla,
Yeah.
these take people who have MCI or
Right.
early dementia.
Correct. But they haven't had the results like improvement in, uh,
No,
yeah,
no
right.
improvement. No.
So what is
So
the comparison that you're making here?
with ours are just as far along. In other words, we didn't want to say, well, we took people who were not as far along, so it was easier to make them better. We took them that were just as far along as the drug trials. The drug trials, the people went down. What they were trying to show is they went down slightly more slowly. Maybe it was borderline, almost no clinical impact. Whereas ours, as you saw in the graph, they went up. Now, here's a very, very important point that most people miss. We've been criticized for, hey, we're only doing in this trial 72 patients. Well, what people miss is when you have a minimal impact, you have to have a lot of people to get a statistically significant effect when it's tiny. So in the drug trials, they have 1,500 or 1,800 people. They spend 50 to $100 million doing a drug trial because the effect is so tiny. So we did a preliminary calculation with a statistician. How many do we need to show statistical significance? And the answer was 60. Now we're doing 72 to give a little wiggle room, and we already have statistical significance. So this idea that, you need to do thousands. Yes, if you have virtually no effect, you need to do thousands. If you have a big effect on your patients, you don't need to do thousands to show a statistically significant impact.
Okay, so I have two more questions. One is, we've kind of known about the impact of the drug Leqembi. Like the cost is one thing, and then, the microbleeds and inflammation in the brain is another thing. We've known about that. Do we know anything about Kisunla? What is the risk benefit profile of that?
Yeah, it seems to be similar to Leqembi, and the outcomes are fairly similar. If anything, the outcomes from Kisunla seem to be a little more delay than with Leqembi.
So, but do you expect that with this blood test that the New York Times published about, that it's FDA approved, it will be covered by insurance, and then people will be become eligible for either Leqembi or Kisunla? That would be the plan, right? So we could potentially expect many more people to start taking these drugs?
I think that's the hope of the drug companies. But those people who are asymptomatic, it hasn't been shown to be effective. So they only tested the ones who already had MCI. So
Sure. So
that's
they're
the issue.
saying that if you have to have memory loss, evidence of memory loss,
Yes.
and over the age of 55, only then this test will be, is allowed for, you're allowed to take it, and then whatever okay. So, so potentially we could see many more people taking these drugs, and then we will see what their outcomes will be. So we'll able to see that. My final question is 84% of people improved in the first trial. Subsequently, I've seen a number of 74%, and in the community, 50%. I think that's the table that you put out yesterday. Can
Yes.
you talk about those two numbers?
Yeah, so it depends on how good you are at doing this. So in the trial, everything was focused on, doing everything possible. People had free treatment, of course. And it was six, well, the first trial, three physicians, Dr. Ann Hathaway, Dr. Kat Toops, Dr. Deborah Gordon, who are very good at doing this. This is very much like surgery. There are people who are really good at it, and there are people who are not very good at it. And in fact, we've looked at the six different sites in the current trial, and no question, there are some sites doing great and some sites doing less well. So it does depend on being good at this. In the community, it's about 50% of people are showing improvement because some people aren't doing it as well. And to be fair, they're not getting it for free. They're not doing some of the things, understandably. So, again, you've got to optimize things.
We are at time and we didn't
Yes,
really get a
thank you.
chance to get into the ageless brain. And I
Next
also
time.
wanted to talk about women's brain specifically. Perhaps we can do a part two at some point.
Sounds good.
Okay, thank you so
All
much,
right.
Dr.
Thank you,
Bredesen. This
Dr.
is
Tony.
wonderful.
Great to talk to you.
Thank you.